As humans, we have an innate need to form and maintain interpersonal relationships that are positive, long-lasting, and significant in our lives. When we're deprived of these kinds of relationships, or when our belongingness needs are only partially fulfilled, we experience this as a feeling of loneliness. So loneliness is socially produced. It stems from the subjective appraisal of social isolation. This means that even people who seem to be socially well connected to others can still experience loneliness that negatively impacts their social, emotional, and behavioral outcomes. Now, I'm interested in GBM and loneliness because members of sexual minority groups like GBM experience homophobic stigma from family and peer networks. These experiences can lead to internalized homophobia and minority stress, which are closely linked with difficulty forming social connections, fewer social supports, and low connectedness to peer groups and the community. So this means that GBM might be particularly vulnerable to developing a sense of loneliness and isolation compared to their heterosexual peers. And this is where the loneliness and sexual risk model comes in. This model says that loneliness is accompanied by emotional distress. So loneliness creates discomfort that drives individuals to seek intimacy at all costs to manage this pain. So among GBM, loneliness is associated not only with negative psychological states like depression and anxiety, but also with behaviors that increase the risk for HIV. Behaviors like substance use, compulsive partner seeking, hypersexuality, and condomless anal sex. This likely contributes to the fact that whereas other key populations have seen significant reductions in HIV incidence, GBM remain at more than 71 times greater risk for HIV compared to other men. So the loneliness and sexual risk-taking model says that sexual risk-taking results from a reliance upon maladaptive coping behaviors to regulate the negative feelings associated with loneliness. Now, social support might be able to help here. Supportive relationships are an important resource for coping. And here I'm talking about perceived social support, which is based on our subjective impressions of the amount and quality of the support that we believe we have available. And we know that social support is associated with lower risk for mortality and has been associated with more recent HIV testing in young Black GBM. So supportive relationships have a direct positive effect on health. But it can also buffer against chronic stressors. Social support can help us form a sense of belonging and meaning in our lives, which facilitates coping. And among sexual minorities, social support has been found to buffer against negative effects of homophobic stressors on emotional distress. However, more work is still needed to understand how social support might buffer against homophobic minority stress in GBM and to understand its direct effect on HIV risk and protective behaviors. So the aims of my fellowship project have been to examine how loneliness negatively impacts HIV and STBBI risk and prevention behaviors among GBM, to investigate whether social support buffers against loneliness-related sexual risk-taking behaviors in GBM, and to develop an intervention trial to determine where adaptive coping strategy trainings are most effective for reducing risky behaviors in GBM experiencing loneliness. Now, in the first year of my fellowship, I've been focusing on the first two goals. So let me tell you a little bit about my findings so far. In my first study, I was looking at GBM and loneliness, and I used a sample of GBM recruited through the Momentum Health Study, which is based in Vancouver. Now, you'll note based on the dates, these data were collected before PrEP was widely available in Canada, so this didn't factor into my analyses. So for this study, I examined demographic factors and sexual behaviors associated with loneliness among GBM. So let's take a look at some of the results. In this study, I found that lonelier GBM tended to report more sex partners in the last 6 months and a lower likelihood of using condoms during anal sex in the last 6 months. So these findings demonstrate the association between loneliness and increased sexual risk-taking among GBM and suggest that interventions that include support to help lonely GBM develop strategies to adaptively cope with their feelings of loneliness might also lead to reductions in HIV transmission. Now, I also found that guys who were out in their about their sexual orientation to their family and peer networks, they also tended to report less loneliness. And guys who reported more social support also reported less loneliness. So these results support an inverse link between social support and loneliness among GBM. So for the next study, I wanted to focus more deeply on the role of social support in GBM sexual health. And for this study, I used a sample of HIV-negative GBM recruited from the Engage cohort study, which is an ongoing cohort study being conducted in Vancouver, Toronto, and Montreal. I used baseline data for this analysis. I examined the main effect of social support on HIV risk and prevention behavior, so the direct effects, as well as the buffering effect of social support against the impact of internalized homophobia. So to kind of summarize this slide a little bit, I found that overall higher perceived social support was associated with a variety of HIV prevention related behaviors and outcomes among Canadian GBM. I found that my guys who reported higher perceived social support had a greater likelihood of seeking HIV testing in the last 12 months. They were also more likely to have engaged in behavioral or seroadaptive HIV risk reduction strategies, like only having condomless anal sex with partners they knew were HIV negative or had an undetectable viral load. They talked about HIV status more frequently with their sex partners, and they were also less likely to have engaged in condomless anal sex or CAS without PrEP at their most recent sexual encounter. I also found that social support successfully buffered against internalized homophobia. Among GBM with low perceived social support, higher internalized homophobia was associated with greater odds of engaging in CAS without PrEP. But among my guys with higher internalized homophobia, they also had high social support. This was associated with a large reduction in the odds of engaging in CAS without PrEP. So those are the two studies that I've done so far. Let me also tell you next about what I'm doing next, what's coming up. I'm currently collecting data through Ryerson to look at two different types of loneliness, emotional loneliness and social loneliness. Emotional loneliness is longing for a partner or a close confidant, somebody like a boyfriend or a husband. Whereas social loneliness is longing for a larger social network, like having a larger group of friends to do things with. I'm going to be exploring the differential associations of these two forms of loneliness with HIV risk and prevention behaviors. I'm also working with the Engage cohort study to look at the impact of the COVID-19 pandemic. I'm going to be looking at how Canadian GBM are coping with the prescribed social isolating and social distancing measures that have been recommended and are being enforced by Canadian governments. I'm particularly interested in how the increased threat of social isolation during the pandemic has impacted sexual risk-taking behaviors among GBM. So this is kind of my to-do list for year 2. So I'm going to be looking to determine which type of loneliness, social or emotional, is more common in GBM, and whether these two kinds of loneliness have different associations with risk-taking behaviors. I'm also going to be exploring how GBM attempt to cope with feelings of loneliness in the context of COVID-19, and I'm going to be working on developing an online intervention to reduce social and emotional loneliness among Canadian GBM. Now, as you might be able to guess from what I've presented already, several of these goals are already in progress, which is great. And I'm looking forward to continuing to work towards completing all of these goals during my postdoctoral fellowship. That's it for me. Thank you for your time and attention. And thank you also to the Momentum Study team at the BC Centre for Excellence, the Engage Cohort Study team, and also to my home lab, the HIV Prevention Lab at Ryerson University, for their support and data.